Dear colleagues, this is John Damlak speaking. Welcome to the 4th International Medical Physics Week webinar organized by the IOMP School. Today the topic is breast imaging and its role beyond cancer diagnosis. We all know the great contribution of physicists to medicine, the discovery of X-rays, the discovery of radioactivity, and first clinical applications. Also the development of computed tomography and MRI would be impossible without physicists. What is not widely known is that in 1965, a physicist from France, from Strasbourg, Charles Gros, developed the first unit dedicated to mammography. Today, another great physicist, Ioannis Sechopoulos, will give us an insight into the impact of new breast imaging techniques, how breast imaging has the potential to revolutionize breast cancer treatment, as Ioannis mentions in his abstract. It's also a pleasure to introduce the moderator, Professor Stoeva. Magdalena works in the University of Plovdiv, Bulgaria, and she also chairs the IOMP Medical Physics World Board. Magdalena, I will switch off my camera and microphone. Please, the microphone is yours.
Thank you, John. Thank you, everyone. Good morning, good afternoon, good evening to everyone who has joined this session. I will not take much of your time, just want to thank everybody for your support during this week. And of course, to introduce our speaker, Dr. Ioannis Sechopoulos, smaller, faster, more advanced X-ray breast imaging and its role beyond cancer diagnostics. Very attractive presentation. Dr. Sechopoulos is the director of the Advanced X-ray Tomographic Imaging Laboratory of the Radiology, Nuclear Medicine and Anatomy in the Medical Center and a scientific advisor of the Dutch Expert Center for Screening. His PhD is from the Institute of Technology in Georgia in Atlanta, United States, and he's performing research in the area of digital breast tomosynthesis at the Emory University. Apart from these activities, Dr. Sechopoulos is or has been a member or a chair of 2 dozens of different task groups associated with the FAAPM, IFOMP, the RSNA, etc. And he's also a member of the editorial board of the international journals Medical Physics and Radiology and associate editor of Physica Medica, the European Journal of Medical Physics. So Ioannis, the stage is yours. Everybody who has any questions, feel free to send them in the chat. Thank you.
Thank you very much. Good morning, good afternoon, good evening. I'm trying to figure out how to share my screen, so allow me for 1 second. I hope now you can see my title slide. I'll take silence as a yes. Well, as I said, good morning, good afternoon, good evening, everybody. Thank you for joining this webinar, and thank you to the leadership of IOMP for the invitation to present some of our work today. Professor Damilakis, when he invited me to give this talk, he asked me to be a bit cutting edge and talking about some of the newest technology that we hope will be coming out over the next few years that we're working on as we speak. And that's why I chose this topic about the role of X-ray breast imaging the potential role of X-ray breast imaging beyond cancer diagnosis, because it's a topic that is usually, treatment of breast cancer is usually not really related normally to X-ray based imaging. And we think we need to change that for improving the treatment of breast cancer patients. So I will just go ahead. First of all, I want to recognize that none of this is my work. All of what I'm going to show today is the work of these amazing group of people. These are most of my PhD students and postdocs. And the best thing I can do is try to stay out of their way for them to be able to generate this very interesting and impactful science. And of course, these days, we cannot work alone. We have the good fortune of working with a great group of clinicians, radiologists, like the ones listed here, Dr. Mann, Dr. Dorsey, Dr. Prokop, Dr. Smith, each in their experts in their own specific specialty in radiology, and of course, many other breast radiologists, pathologists, oncologists, and surgeons who have inspired this work and are helping us guide this work to be clinical impactful. Along with other scientists that are agreed to collaborate with us and having worked with us, some of them for over 10 years, like Dr. James Nagy, a mathematician from my previous institution at Emory University, Dr. Longo from Trieste in Italy, and Dr. Kacharis from the KFZ in Germany. As you all know, science today takes a lot of people and a lot of disciplines to be cutting edge. And these are my disclosures, which are not relevant to today's work. One thing I do want to say is I want to thank, again, IOMP for this opportunity. Usually, it doesn't happen very often that I can not wear shoes while I'm presenting. This is actually the first time I'm able to do that. It does happen very often that I wear interesting socks, and this is one of my favorite pairs, and it's very relevant to my life. So I will not show them to you right now, but I thought it was interesting that in these days, sometimes we have little positive aspects of our new lives. Okay, but to the project. So as you all know, with breast cancer care, we can think of it as a continuous chain of stages. Women are either diagnosed with breast cancer as a result of screening, where we detect cancers earlier, or because of clinical concerns. If at screening something is detected, they go to the hospital for diagnosis. If imaging confirms that suspicion, women get a biopsy. If the biopsy is positive, of course, now they become breast cancer patients. The cancer needs to be staged to determine how large it is. Is there nodal involvement? Is there more than one tumor in the same breast, or even tumors in the other breast? And then, depending on the answer to all those questions, it needs to be treated in one of several ways. And eventually, hopefully, the woman is cured and she goes back to some sort of screening, which might be the original one, or specialized screening for surviving women. And if we look at the imaging aspect of the breast cancer care chain, of course, screening is done with mammography or tomosynthesis these days, and it's the prime technology used for screening. And diagnosis is ultrasound has, of course, an important role along with mammography and tomosynthesis. MRI has a role in staging, depending on the institution and the protocol in the country. But treatment is one part where there's a very small, right now, role in terms of imaging. Once we decide what treatment route the patient is going to undergo, she doesn't really receive much imaging during therapy to guide that treatment. At most, and depending on the institution, she might get one MRI during the neoadjuvant treatment, or maybe one ultrasound, but that's about it. The imaging doesn't have a clear, impactful role in treatment. So what are the treatment options that women have when they are diagnosed with breast cancer? Well, there's two options: either a radical mastectomy, in which the entire breast tissue is removed, or breast conserving therapy, which means lumpectomy, in which only the area where the tumor is, the tumor and the surrounding area is removed by surgery, followed by radiotherapy to kill off any remaining tumor cells and to decrease the possibility of recurrence. Now, it's become more and more common for women to undergo this treatment option of breast conserving therapy before getting lumpectomy, to undergo some kind of neoadjuvant treatment. So this could be chemotherapy, hormonal therapy, or some other type of drug related. Now immunotherapy is becoming more common. The idea of neoadjuvant treatment is to shrink the tumor, ideally make it disappear completely under pathology. And when the woman responds well to the neoadjuvant treatment, then the lumpectomy, then breast conserving therapy can become an option sometimes when it wasn't an option initially before neoadjuvant treatment, or it becomes breast conserving therapy will have a better outcome long-term if the neoadjuvant treatment before the surgery and the radiotherapy was successful. Complete response to neoadjuvant treatment, pathologically confirmed, what we call pathological complete response, has been associated with an increased survival rate in women undergoing breast conserving therapy. So we want, when women undergo neoadjuvant treatment, to at the end of treatment at surgery, that sample to be analyzed by pathology and for no more viable tumor cells to be found. That is the ideal case. Unfortunately, pathological complete response is only achieved in about 40% of neoadjuvant treatment cases. So the majority of times we do not get what we want, and as I said, what is associated with increased survival. And why is that? Well, we're not exactly sure yet of all the causes that makes neoadjuvant chemotherapy fail or not achieve the optimal outcome. But one of the reasons that we are becoming more clear that now we know from the last few years is that tumors are actually very heterogeneous, which means we've all heard of HER2 positive tumors, ER negative, triple negative, all these different types of molecular profiles of tumors. But those are, let's call them summaries of the entire tumor. And now we know that tumors can have small areas that have different profiles. They either have, the tumor itself might be HER2 positive, but it might have some small areas that are HER2 negative, and therefore, if we target them with a chemotherapeutic that is for HER2 negative tumors, for example, then that other area doesn't respond. And these groundbreaking papers by the group from the Moffitt Cancer Center, they've come up with the idea of habitats. Tumor have habitats, have small areas that develop differently because of the microenvironment in the tumor leads them to be this way. And this histopathological analysis of a tumor section, you can see in blue an area that is more necrotic due to hypoxia, an area that is more viable, still viable after treatment, and this red marker, and you can see here that it's shown in violet. This is a marker for hypoxia, and you can see it affects part of the tumor but not the rest. And this is all under pathology, so this is what we consider truth. Now, before excision, this tumor was imaged with multiparametric MRI, and analysis of the MRI can actually determine the same information from the tumor than we found from the histology, and it is co-registered. You can see here we compare the MRI findings to the histology. Things seem to match very well. And there are other studies, and we've seen that imaging can be used to characterize the biology and the molecular profile and the recurrence, for example, the recurrence risk of different tumors just from imaging features. Now, one issue, I want to go back for a second. One issue I should say that, of course, when we diagnose a tumor, we have a biopsy that gives us all this information about the sample that we biopsy. But when a tumor is biopsied, we get only a few samples throughout the tumor, but we cannot, it's impossible to do a histopathological analysis of the whole tumor from biopsy, because biopsy only samples a certain discrete number of places. So there's no way using pathology to, before surgery, to actually characterize every little portion of the tumor. So the answer for that needs to be imaging. So as I was saying, using MRI, and especially dynamic contrast enhanced MRI, we have studies that show that we can find imaging-based features that predict recurrence risk, in this case, 10-year likelihood of recurrence. We can predict pathological complete response to a certain high degree of accuracy. And we can actually predict responding tumors from non-responding tumors, again, using MRI to some degree. But all this imaging, this is all based on dynamic and multiparametric MRI, is limited to the whole tumor analysis. So we're predicting response, final response outcome, possibility of recurrence, and such items, but not characterizing the subtumoral habitats present in each tumor. And as one of the scientists that has been doing this MRI-based analysis of tumors to find their characteristics and reactions to treatment, has said that, you know, we need higher temporal and spatial resolution imaging to be able to analyze the tumor in these ways, but down to the subtumoral level. So we can find and we can determine what exactly is in the tumor in terms of molecular profile, cell density, and even eventually genetic profile of the tumor, and therefore be able to treat every single little part of that tumor. So this is a little bit of the clinical background. What I need to jump now is to give an introduction to new medical imaging technology, or relatively new. This is about 10 years old, which is dedicated breast CT. Now, for those of you who are not familiar with this technology, I need to show you a few videos. Dedicated breast CT is a CT system that has been optimized for breast imaging. So the geometry, the physics, the medical imaging physics, let me see if this will start. There we go. So this is a CT system that's been designed specifically for breast imaging. We have an X-ray tube and a flat panel detector that rotate around a vertical axis around the breast. It acquires 30 frames per second, a total of 300 frames around the 360 degrees to eventually end up with a CT image of the breast. This is what the system looks like, the one installed in my hospital, and you can see the bed. And if you open inside the system, you can see here, I know my pointer is a little bit small, but you can see over here is a flat panel detector, and somewhere in here is the X-ray system, and this is where the breast pans through that hole. And you already saw this whole thing would rotate around the breast. And the 300 projections look something like this. They don't necessarily look anything interesting because, of course, these are the projections before reconstruction, but just to give you an idea. And then once we reconstruct, we can cut, or I can show you the coronal cuts through the breast going from the nipple towards the chest wall. And you can see the dark tissue is the adipose fatty tissue. The whiter light gray tissue is the glandular tissue, and now we're at the chest wall. And if we do a 3D rotating maximum intensity projection of that acquisition, this is what it looks like. You can see very nice detail even of the skin pores and the inside of the breast. I must say the radiologists usually look at the three views, the three orthogonal views of the breast CT, like here on the left, rather than that rotating MIP. But you can see here very clearly a lesion that has a fat core, and therefore this is nothing. This is not a cancer that needs to be biopsied, as opposed to a mammogram where you can see it's very hard to even see the lesion, let alone the inner detail of it. So this technology is clinical now. There are a few commercial systems for dedicated breast CT that are approved for clinical work, and there's a few installations around the world. And we've been doing research on these systems for, I would say, around 10 years. This is another example of microcalcifications, how they appear on the image on the right, in the right slice of the breast CT. As I said, we've been working with this technology for a few years. Of course, this is cone beam CT, so it suffers from X-ray scatter being detected in the flat panel and reducing the contrast and the accuracy of the images. So one algorithm we proposed that requires a second set of projections, but extremely low dose, less than 5% of extra dose, by using a perforated plate in front of the X-ray beam before the breast. You get an array of pencil beams that are detected, and at those locations you only have primary non-scattered X-rays, and from that you can calculate the X-ray scatter in the real projection and the difference. And when you take the difference, you end up with only a primary image. And we've shown that doing this sort of scatter correction increases the quantitative accuracy of your imaging. This is a phantom with a few inserts. This is supposed to be adipose tissue. This is glandular tissue. And these are the supposed Hounsfield units of those two materials. And if we don't correct for scatter, this is the numbers that we get. And once we correct for scatter, you see our accuracy and our contrast is increased. There's a little bit of overcorrection for the background, but okay, it's still much more quantitatively correct. We're actually doing this type of scatter correction now on all our patient images. And you can see on the left, the image without any scatter correction, it suffers from some cupping. You have a lighter gray in the surrounding outside of the breast, the outer areas of the breast as opposed to the center, typical of X-ray scatter. The system has its own correction to flatten that image, but it's not specifically scatter correction, so you don't get the increasing quantitative accuracy that you get by doing this hardware and software-based combination. One other development that we've introduced for dedicated breast CT is the idea of dual spectrum reconstruction. This is not the same as dual energy imaging. This works differently in that one thing that happens in all of CT reconstruction is that filter back projection or any other current iterative reconstruction algorithm assumes that all the X-rays used to acquire the CT projections are all of the same energy. And this simplifies the reconstruction problem a lot, significantly, making the mathematics a lot easier and allowing for much faster reconstruction. Now in breast imaging, in breast CT, the X-ray spectrum is a lot softer than in body CT, and therefore the beam hardening, the change of energy that's happening as the X-rays go through the breast is much higher, much more intense, and this results in a much higher inaccuracy when we're facing this assumption of X-ray being monochromatic in breast CT rather than body CT. So we wanted to avoid that, so we introduced this reconstruction algorithm that includes this forward model in which we set up this equation of what is happening when we acquire these breast CT projections. And the key thing is that we decompose the breast into two base materials. And since this is a breast, the typical materials to decompose are glandular tissue and adipose tissue. So in essence, what we're reconstructing is not one breast image, but two breast images, one representing where is their glandular tissue and one where is their adipose tissue. So this model includes, well, the two images that we're trying to reconstruct to obtain, the geometry of the system that we know, the attenuation coefficients of the two base materials, adipose and glandular tissue, which of course we also know, and the X-ray spectrum and the characteristics of the detector that's used in the breast CT system, which we also know. We can model the X-ray spectrum that is used by the system, which is something that looks like this. And of course, the left side of the equation is the actual breast CT projections in this format, in the sinograms that we actually acquire, the measured data. So we go through this reconstruction algorithm. The idea is to invert this process and end up with these two images, W, which represent, well, where is the breast glandular tissue and where is the adipose tissue in the breast, and that is the reconstructed image. Then we can combine those two images into one and show them to the radiologist just like a regular image. So the standard imaging process is something like this, right? We rotate the X-ray source in the detector on the breast, we acquire the sinogram, and we end up with this image. But by including the X-ray spectrum in the reconstruction equation, now that means we can actually change it during the acquisition process, and this reconstruction still works. So what I'm saying is, as we spin around the breast and we acquire each projection, we actually switch from one spectrum to a different one, and we acquire two sets, half sets of projections. One at low energy gives us better contrast. This sinogram, which is acquired with an X-ray spectrum that has, in essence, in overall lower energy, has higher contrast, but it's noisier because lower energy spectra transmit through the breast less. And this second spectrum that is higher energy on average, and therefore it's has less noise, but suffers of lower contrast. Now we can input these two half sinograms into our reconstruction algorithm with the correct two spectra. We just need to change this term, include the two spectra, each one with a corresponding set of projections in the model, and we can still get a good image. And actually, doing the mixing of the spectra, in which we acquire half the projections with higher energy and half the projections with the regular energy, gives us an image that has the same image quality characteristics. Here you can see this is the original image with the original spectrum standard imaging. This is the one that is half and half, and we have the same image quality, but at about a 35% reduction in dose. Of course, we can go the other way and improve the image quality and have the same dose, but for this, we were interested in decreasing the dose of breast CT. This worked so nicely that we actually added this filter switching mechanism to the breast CT, and you can see this includes a copper filter and a standard aluminum filter, and it rotates at the speed so that each projection, remember this is 30 projections a second, is acquired by one of the two filtered spectra. Now, one modification we could do to this reconstruction is add a third base material, which in this case is iodine, of course, as a contrast agent, and then we can actually, instead of reconstructing to two base materials, we reconstruct to three, and the third one is iodine, and we get a iodine only image without actually having to do subtraction of high energy reconstruction minus low energy reconstruction as it's usually done in dual energy imaging. And you can see some results, and we can show that we have a decent, although we're not quite there, quantitative estimate of the actual iodine concentration in these added inserts in this breast phantom. So we have been working with regular three-dimensional breast CT to improve, lower the dose and improve the image quality. And one other thing that we've been doing is, well, now can we do more with these images than just show them to radiologists? And that's where the idea of radiomics comes in, and more computer analysis as opposed to only human interpretation. So, of course, radiomics is nothing new. We're trying to analyze images quantitatively to figure out well, the answer to any question that we're having. And we have done some work on radiomics for mass characterization to tell if a mass is benign or malignant. And this includes looking at its texture, its shape, its margin. Of course, we first need to automatically segment the lesion, and then, of course, these days we use a deep learning algorithm that has been trained by manual segmentation of these masses. And this is, for example, the average of the radiologist's manual segmentation compared to the automated one. This is a relatively easy lesion. This one is a much harder lesion that still the deep learning based algorithm can segment totally automatically correct. Once these lesions are segmented, they can be analyzed, and all these hundreds and hundreds of different features. Let me give you just one example of one of them. As you can see, benign masses on the left, 3 examples of malignant masses on the right. If we look at the boundary, at the edges of the lesion, malignant masses, of course, tend to have more irregular borders that can be quantified using something like the centroid distance function, which once you turn it into the frequency domain, you can see a clear difference in the frequency components of that edge descriptor. So of course, radiomics is all about doing this for hundreds and hundreds of different features. In this case, there are over 1,200 features that were analyzed, and from this sort of data, we can actually tell apart benign masses from malignant masses with an accuracy of 0.94. Of course, this today, the next step of doing this is, of course, is with deep learning instead of, or in addition to this more learned feature set. And this is something that we're working on. But the benefit of this, the addition of these learned, well, handcrafted feature set is that you don't need as large a data set as what you need with deep learning. And of course, when we're talking about breast CT, which is not in widespread use clinically around the world, our data sets are still quite small. So for now, we see that this is beneficial, and we see that there's a space for the combination of traditional machine learning with deep learning, but eventually when data sets become large enough, then deep learning will probably do just as well or better than these handcrafted feature analysis. But all of this has been in preparation for the next step. And what I want to show, when I show this is, all of this is anatomical imaging, right? We're just looking for the right shape or the wrong shape in the breast. We're not really looking at how the tumor or the breast is working. What we need is functional imaging. We need to determine how the tumor is working, if it's dying, if it has a necrotic area, or if it has different molecular or even eventually genetic profiles, and using imaging to do that. So we want to move further beyond 3D breast CT to 4D breast CT, and that is dynamic perfusion dedicated breast CT, and in this case, continuous acquisition of dynamic perfusion imaging, and therefore that's why we call it 4-dimensional breast CT. So the idea is, of course, this includes the injection of contrast, iodinated contrast to the woman, which is very safe and very common in the hospital. And then once the iodinated agent has been injected, we will scan with our 4-dimensional breast CT system. For the truth is, we still don't know and how long we need to scan, and there will be interesting biological information there, 3 to 5 minutes. Technically speaking, we'll be able to scan up to 5 minutes. And then we will decompose our projection and reconstruct the iodine-only image. So if you look at the top right, we're going to be able to see the perfusion. That was the tumor in which the iodine was coming in and then perfusing out and then the rest of the glandular tissue washing in and out. And from that, we will analyze quantitatively each and every one of those voxels within the tumor and in the surroundings to be able to relate that to the different molecular, genetic, and different information of the tumor. So as I said, it's not only about showing this four-dimensional movie to the radiologist, but more about doing some image analysis to be able to extract characteristics of the tumor automatically. So the first step in building such a system is, of course, designing the hardware and optimizing the acquisition. And this is where a lot of software simulations have gone into. First, we needed a 4D software breast phantom, from which we used as a starting point. We actually used our 3D patient breast images. So these are just patient breasts that we acquired in our hospital doing our research, and in combination with Dr. John Boone at UC Davis. He also provided his research breast CT images, and we developed this segmentation algorithm to be able to segment the skin, the glandular tissue, the vessels, and of course the remaining adipose tissue in there. But this was, of course, this is at the spatial resolution of the breast CT. And if we're going to use these phantoms as representations of the continuous breast in the breast CT back in the simulator of the 4D breast CT, we need to increase the resolution of our phantoms. So we had to come up with an algorithm that takes the regular spatial resolution breast phantoms to higher resolution. So we increase, in essence, the resolution of breast CT images. I'm not claiming that we improve the quality of breast CT images. We're creating phantoms, so we're actually inventing new data. That new data is based on realistic breast features. And for that, of course, we use a deep learning algorithm that we trained with higher resolution images. And those higher resolution images were obtained from, as I mentioned, Dr. Longo, one of our collaborators from Trieste in Italy, where she has a synchrotron-based breast CT system that with a spatial resolution with a voxel size of, I believe, 64 microns. So of course, we can downgrade the resolution of those real breast tissue sample images, and then train the network to do the opposite. So a few examples of how this network not only increases the resolution of the image, but also adds features that would be lost in a lower resolution system. So we go from a standard resolution breast CT tissue examples to higher resolution, and a few more examples of what different pieces of the phantom look like. But we're also interested in the temporal domain of the blood, iodinated blood circulating through the breast. So we had to add a 4D component to it. So we had to simulate, and this now becomes a 4-dimensional software breast phantom, the iodinated blood entering and washing out of the breast, and entering and washing out of tumor models, either homogeneous tumor models like this one, or well, first of all, more malignant like behaving tumors in which the wash in is rapid and wash out is rapid, or more benign looking tumors in which wash in and wash out takes longer and is not that intense. And we have some more ability to simulate homogeneous lesions and rim enhancement lesions. So overall, when we put all this together, we end up with this 4-dimensional software phantom in which we have a tumor that, if it's malignant, it enhances highly quickly and enhances and washes out. And then the rest of the tissue, especially the normal glandular tissue, enhances to some degree because of we know the background parenchymal enhancement effect, and so forth. And we can change the input parameters of the phantom so that we can simulate any type of enhancement pattern. So we take this 4-dimensional phantom and we put it in, and we created this 4D breast CT system simulator. And that for that, we replicated what happens in the physics of a REST-CT system, ray tracing for the primary X-rays arriving at a detector, a scatter estimate, and the detector response. So of course, if you only do the ray tracing, you have a perfect image with no noise, no scatter, no detector effects. We use a Monte Carlo simulation to estimate or predict what the scatter for such a breast would be. And we add it back, and so you get the typical cupping artifacts of a scatter. And then the detector response to the incoming X-ray, so you have a resolution loss and noise. So you end up with projections with all the effects of a real breast-CT system, and this is what a projection will look like, and you see the profile through this simulated tumor. So of course, all simulations have to be validated first. So we compared this simulation of a 4D system acquiring a single 3D image to what we could do with this 3D system that we have available. And as you can see, profiles look reasonable. As you increase the dose, you get lower noise image. A more quantitative comparison, the signal to noise ratio in acquired images versus simulated images matched nicely. The Hounsfield units of different lesions with different equivalent densities also match nicely between a real phantom, really acquired image versus a completely simulated one. And even a phantom in which we added iodine to it with 4 different concentrations, we can again simulate such image correctly. And then that's when we can then turn on, once it's validated, our simulations of 4D breast-CT imaging. And now you can see a full sequence of data acquired from what would be a 4-dimensional breast-CT image. This is a simulated tumor in our 4-dimensional breast phantom. And if you acquire 300 seconds worth of data at very low dose, this is approximately this is what 2 voxels, one in the tumor, one in the parenchyma, give you. Of course, it's extremely noisy. If you increase the dose somewhat higher, you do get a little bit less noise in your profiles. But again, this is some examples of the signal that we get. This is the truth in the simulation over here to the left, and this is what the images really look like. And it might not look like much, but hold that thought, because this is just the raw reconstruction that needs many corrections. And we are working to develop these corrections. One of them is, of course, motion correction, and this is 2 parts. Overall motion correction between reconstructions, because if we are doing imaging at very high resolutions for 5 minutes, you can imagine the breast will move, and this needs to be corrected for. And a key motion correction algorithm that we had to develop in collaboration with Dr. Kacheris in Germany is within one projection set, within the 300 projections that we acquired during those few seconds, if the tumor moves or the breast moves, what will happen? So we can simulated a tumor moving up to 2 centimeters during one single acquisition. And with our motion correction algorithm, you can see that we can recover back the tumor quite nicely as if it hadn't moved at all. So this is a key component for our quantitative analysis. We also had to develop a noise reduction filter that would allow us to do this quantitative analysis of this voxel in a reasonable way. And this is how what it can do. I'm looking at just a single voxel right now. This is a true signal. You can see it goes up and then it goes down, and it's sampled at 30 time points. And if I add an immense amount of noise, you can see the standard deviation of this, and this signal I just added is equivalent of 0.5. That's what it looks like. So say I have 3 voxels with 3 different truths behind them, and you can see the difference between the 2 most different voxels have a max difference in signal of 0.6, and I'm adding a noise with a standard deviation of 0.5. So I really am at a very, very low signal to noise ratio environment, which is what we expect. And now I created an image with approximately 500 voxels of each of these signals behind them. Of course, they all have this random degree of noise. And we use what we call a tissue similarity filter to filter these profiles. And this is what we get. I'm showing you here 3 voxels. This is the truth. The ones in dashed lines are the truth. And this is the real data after we filter it. And you can see how, even though we had this as input, what came out was this. So you can see the power of this filter. And since we're imaging physicists, I'm going to show you one slice of one time point of this simulated breast image, breast perfusion image. And you can see on the left is without the filter, and on the right is with the filter. And the arrows are showing 3 vessels and the tumor itself. And so you can see how we can recover very high degree of signal. And if we look at the performance of this filter, you can see on the same horizontal line, that means equal image quality, right, in terms of noise. But as we go to the right, that means we need a lower dose to acquire the same image after filtering. So you can see from a unfiltered image, we can apply the filter and reduce the dose by a factor of 4 and end up with the same signal to noise ratio. And so it's this, in part, is this filter that allows us to introduce this whole idea of 4D breast CT and still be at a reasonable dose. So to summarize, we are in the process of building, actually over the next year and a half, this 4D breast CT system. We have done all the, a lot of the software simulation to design the system. We will be able to acquire up to 5 minutes of continuously with this dual spectrum acquisition format that we've come up with. We calculate that we will need a mean granular dose of 15 to 25 milligrays. Yes, that is considerably more than screening, but remember, this is for already diagnosed patients that already have breast cancer that eventually will get radiotherapy, which is 1,000 times more dose than this. We'll have a temporal resolution of about 3 seconds with a voxel size of 70 microns. We will look at the quantitative iodine-only images thanks to our spectral reconstruction with material decomposition after scatter correction and motion correction and noise filtering like I showed you. The idea is to give this image over to an AI algorithm that has been trained based on histopathological truth. From that, we will be able to get details of at the subtumoral level of the tumor reality. As I said, the training will be done using histopathology. It needs to be large section histopathology so we can have spatial correspondence. And from that, we will learn the cellular density distribution in the tumors, and the vascular access differences in the tumor using an endothelial cell marker. And we believe we will be able to characterize the molecular profiles within each individual portion of the tumor. And eventually, although this is not part of the current project, is even the genetic characteristics of the tumor. So with that, we'll be able to, we believe, improve staging and the detection of multifocal, multicentric disease. The most important part is we were going to be able to take into account the actual presence of all the different types of tumor inside one tumor to personalize neoadjuvant treatment, to do continuous response monitoring to the treatment, predict final response, aid with surgery planning, and the pie in the sky is if we can assure that we achieve pathologically complete response, in essence, we don't really need to do surgery anymore because the tumor will have disappeared completely only based on the neoadjuvant treatment. So once we achieve that and we show that in the clinic, we hope that then imaging will have a key part on every stage of breast cancer care, and especially as I described today, the 4-dimensional aspects of breast CT will have an impact on treatment. So that's what I wanted to show today. And I should say that all this research has been funded by the National Cancer Institute of the US, and the next step is starting to be funded by the European Research Council here in the European Union. So thank you very much for your attention.
Thank you very much, Ioannis. Such a wonderful presentation. And the audience here is very active, commenting, sending their feedback, which of course is very positive. We do have a large number of questions. Of course, due to the interest of time, you shall be able to answer only a few of them. So let me start with the very first question that was posted. It came from Arun Chugule from India. And the question is the CT for breast imaging commercially available? And if yes, the company manufacturing? To Arun's knowledge, the University of California in LA developed such scanners about 10 years ago. Could you please comment on this?
Yes, so there's if 3D breast CT is commercially available, there's at least two companies, one from the US and one from Germany, that have commercial systems. And the group at UC, University of California, Davis, directed by John Boone, has also, of course, he's probably one of the earliest developers of breast CT. All these systems that are commercially available or have done a lot of work are three-dimensional systems, so they acquire single images, not this four-dimensional aspect. But yes, at least two of them are clinically available in Europe, and at least one of them is FDA approved for the US. And I understand that there's quite a few installations in for example, China, from Corning Corporation, and the German company is called ABCT, if I remember correctly. So short answer is the 3D breast CT is commercially available. 4D breast CT doesn't exist in hardware yet.
Thank you. And then we have a question from Alessandra Tomal. For the polychromatic forward model, did you use two basis material, adipose and glandular tissue? Was the skin extracted from the glandular information, since both glandular and skin had higher attenuation coefficient compared to the adipose tissue?
Yes, so yes, so the skin is represented as a, let's say, higher density, higher glandular tissue, higher than 100% glandular tissue, let's say.
And our third question from Vasilios, for the DQCT, how you are improving the noise at the higher voltage CT, and also what is the range of spatial resolution of your image, and what do you think for the co-registration role of MR spectroscopy in addition with breast CT?
So if I understood the question correctly, so the higher spectrum, higher energy X-ray spectrum is by inherent physics lower noise, because you get more transmission through the breast. As we know, higher energy, you get a higher signal of the detector, but of course you lose contrast, and we compensate for that by acquiring the other half, which is the lower energy spectrum projections. And it seems to work, the idea that we get good noise characteristics from half the projections and good contrast characteristics from the other half. Yes, MRI spectroscopy, I guess it could play a role. MRI spectroscopy is, I would say, more of a point analysis, not usually, at least I'm not an MRI expert, but from all the times I've seen it, is more of a one single voxel analysis to get a chemical signature, but not whole tumor or whole breast analysis of what we hope eventually will provide information of molecular profile and such. But I can see how it could be used as a validation, or for yeah, as a validation of these methods.
Thank you. And since radiation protection plays an important role in our profession, I have selected here 2 questions related to the radiation safety. The first one is from Ibrahim Duhaini, who is asking, what is the radiation safety aspect during the 5-minute scanning, and how much dose to the patient would be? And then the second question in this area comes from Ioannis. He says, hi Ioannis, have you considered the impact of overdiagnosis and or overtreatment from increase in resolution, spatial and temporal, and addition of perfusion imaging? In other words, is all this extra imaging beneficial to the patient? Have you shown from critical trials a reduction in mortality from the use of this modality as opposed to the current gold standard?
Okay, so the dose aspects, so I only mentioned at the end, so thank you for the question. From our simulations and our estimates, our dose for one full sequence of 4D breast CT acquisition will be, well, our results are 15 milligrays, but of course there's still a lot of optimization to go, and that's why I mentioned 15 to 25 milligrays. Now, to put that into context, one screening view of mammography, or let's say tomosynthesis, is more closer to 1 to 1.5 milligrays. So we are talking 10 times a screening acquisition. But, and this is a very important but, we are aiming this application, at least as a full 4-dimensional sequence, only for treatment planning and, well, everything to do after diagnosis. So the woman already has breast cancer. She's not being screened or even diagnosed. She's already been diagnosed with breast cancer via biopsy, and now we want to treat this cancer. And the women that will receive neoadjuvant therapy, in which this imaging technology is especially useful, and eventually surgery, will eventually receive radiotherapy. And radiotherapy, now we're talking doses in the levels of grays as opposed to milligrays. So yes, you could argue, and we also argue, and that's why we're doing everything we're doing to optimize this to have a low dose. But we're not concerned with the dose to the level of when we are concerned with the dose at screening or even at diagnosis. And especially because these women, after this is done, will eventually get 10 grays of or whatever it is of radiotherapy. So that tissue will be exposed to a treatment dose that is much, much higher. And the breasts that do not undergo lumpectomy and radiotherapy will undergo mastectomy, and therefore the whole tissue that is irradiated with this 15 to 25 milligrays per series will be extracted. So then in that tissue, that dose is not concerned at all. And we do have prior simulations showing that the dose to the rest of the body is extremely low, even for these somewhat higher X-ray energies. About the other question, no. So I think, and then it became clear that we are still at the development stage. No woman has ever been imaged with 4D breast CT yet, because this system doesn't exist yet. And of course, we're not concerned that this will increase over diagnosis or any of those controversies of screening, because this is as I said, imaging application is post-diagnosis, so it's only at treatment. So we're not concerned about that. I think that was part of the question. And are we sure we're going to have well, have we demonstrated a clinical impact? No, well, no, of course not. That is the next stage. The first stage is developing the technology. And then once we do the clinical trials, which are part of this multi-year project that we're about to start, we will know the actual impact of the system. I think that was all.
Thank you very much. I checked the chat feed, and we also got a thank you from Ioannis, who asked actually the last question. So with this, we reach the end of our webinar. The recording from the webinar will be available online at the IOMP website by the end of the day tomorrow. I would like to thank once again first to the speaker, Dr. Sechopoulos, then to all the participants that have been supporting us during this Medical Physics Week. And now I give the stage to John to close this webinar.
Thank you, Magdalena. Thank you, Ioannis, for your excellent presentation. And many, many thanks to 500 colleagues who joined for their active participation. Judging from the numerous thank you messages we are receiving, I understand, Ioannis, that participants are most appreciative for this lecture. Very, very engaging presentation. Again, thanks a lot for sharing your knowledge with us. So, tomorrow, same time, another webinar on radionuclide therapy patients. Don't miss it. See you tomorrow. Bye-bye.